all doctors. Warm welcome to all of you for this wonderful evening. We have a wonderful topic for today. It's about alcoholic liver disease and alcoholic hepatitis regarding the challenges in diagnosis and management. So to take this session, we have Dr. Arun N. He is the Assistant Professor of Gastroenterology in the Department of Digestive Diseases and Health, Kilpauk Medical College, Chennai. And he is also the consultant of Apollo Main Hospital's Greaves Road, Chennai, and is the director of Chandra Gastro Clinic and Endoscopic Center, Chennai. His areas of interest are post-liver transplant immunosuppressive guidelines and plasmapheresis in ACLF. And he is a life member of ISG, INASL, SGEI, and IAP. A warm welcome to this wonderful evening, sir. Kindly take over the session, sir. We are honored to have you, sir. Thank you, sir.
Thank you, Microlabs, for giving me a wonderful opportunity to share some knowledge what is going to happen for the next 1 hour regarding the discussion about alcoholic liver disease. And good evening, respected professors, senior consultants, and dear friends who are being here participating in this Sunday to discuss about one of the most common entity in gastroenterology and hepatology that we are coming across day-to-day life in Indian scenario is nothing but alcoholic liver disease and alcoholic hepatitis, the various challenges that we are going to face upon. So to discuss about this alcoholic, there is based upon the clinical presentation, epidemiological series, as well as pathogenesis, these are all the outlines we are going to discuss. See, based upon the epidemiology, if you are going to discuss about this alcoholic liver disease, one of the most common entity. If you're going to see in an ICU setup in India, around 20 to 25% of the population is going to be hospitalized mainly because of this alcohol-related liver pathology. That has been given, multiple data has been there to prove that. So once a patient is going to be having evidence of continuous intake of alcohol, the patient can land up with multiple, first they may land up with steatosis and another complication, followed by, if the patient's alcohol intake is going to take off, followed by the patient may land up in alcoholic steatohepatitis, followed by the patient can go for cirrhosis, and dreadful hepatocellular carcinoma can also develop. So liver cirrhosis is almost the 12th leading cause of death in the United States, and almost 3rd to 4th cause which has been documented well in India. So alcoholic liver disease accounts to around 40% of death from cirrhosis, and 30% of the cases are being from mainly because of hepatocellular carcinoma being reported in this. So if you're going to look into this, universal data of 2020, what they've been taken almost 4 lakhs, more than 4 lakh population of death is mainly because of cirrhosis, and among the female deaths also being reported, and among them 1,56,000 female population throughout the global area has been reported because of alcohol. And moreover, the female population is more vulnerable for this alcohol use, and in India, the female population who's going to take alcohol is slightly going very high when also in the target population of male. So Indian scenario is almost more than 60 million population are being consuming various forms of spirits they are taking, along with the Professor Sarin all being what they may mention, the age of presentation was less when compared to the Western world. That's been documented from ILBS, and liver involvement, the predominant will be will appears earlier and with lower consumption when compared to the West in Indian population has been documented. See, as you all know, that the various alcohol is being there. So if you're going to take beer, if you're going to take wine, if you're going to take or if you're going to take toddy and other things, suppose, so if whatever the proportion of alcohol, if you're going to consume, suppose if you're going to the alcohol content will be around 5% in beer, will be almost, the amount of alcohol will be around 14% in that, and along with that wine also will be around 14.2 grams, and or if you're going to consume 140% of alcohol content will be there. Even if you're going to consume 1.5 hours of serving size, it may lead to amount of alcohol 14, but see the serving size for this. So beer, if you're going to take only 12 hours, and if you're going to take wine, if it is around 5 hours, and if you're going to take odd liquor, there are multiple simple formulas are there to derivate. So calculate this equation, but that's not the main area for me to discuss right now. And see, if you're going to discuss about this alcohol, the most potential toxic dose for which the patient can land up in cirrhosis, if the patient is going to either it's being a male or female. So why female population is slightly becoming vulnerable? Because of estrogen abnormality, also because of COP pathway. There are so many other things being proven to consume for this female population also to be landed with alcoholic liver disease and other pathology. So Men, if he is going to consume for more than 40 to 80 grams per day, and women if she's going to consume for more than 20 to 40 grams per day. And regarding the safe drinks, will be always around 2 drinks per day in men and 1 drink per day in women. And fatty liver, if you're going to consume around 120 to 150 grams per day for 2 to 3 weeks, as per AASLD statement, that's been clearly mentioned that the patient can land up with alcohol-induced injury and other complications. So what is the binge drinking? So binge drinking, what do you mean by NIA, National Institute of Alcohol Abuse and Alcoholism? So what they mention about that, if you want to document a patient with binge drinking, which is very common scenario being reported in India. So what is the binge drinking? The level of blood concentration will be going more than 0.08 grams per deciliter. If the man is going to be consuming more than 5 drinks per day, and women, if women is going to take more than 4 drinks per day in a period within 2 hours, that's almost been labeled the diagnosis of binge drinking. So this is about the semiology of the presentation. So if you're going to discuss about this alcoholic liver disease, steatosis, fatty liver, followed by steatohepatitis, followed by fibrotic changes, followed by cirrhotic changes, followed by hepatocellular carcinoma. That's the final thing which is going to land up, as we all well know about that. So how many percentage, what's the semiology of progression for this alcoholic liver disease to exist? If you're going to take alcohol for more than a period of 4 to 6 weeks, so without any evidence of abstinence, the patient, there is high possibility for the patient, more than 90% of the population can go for steatosis, which is nothing but fatty liver component. So it's going to develop if the patient is going to consume alcohol. And once the patient is going to consume, even after that, 20 to 40% can land up in fibrosis, and 8 to 10%, 20% of the population can go for cirrhosis, and around 1 to 4%, or maximum up to 3 to 10% of the population can land up in hepatocellular carcinoma. So in this period, during this period, we need to stop alcohol. If the patient is going to stop alcohol, so there is high possibility for this fibrotic changes to improve from steatohepatitis for almost, the patient can go for steatosis stage in around 10 to 35% of the population. And also the patient can go for the recovery of the symptoms. The fatty liver and other components can improve over a period of time if the patient stops alcohol during the period, during the course of consumption. So there are multiple risk factors for you to predispose to with alcohol. See, if you're a female population, you are highly vulnerable to that. If you have any coexisting pathology, see, always you should remember alcoholic liver disease is only a diagnosis of exclusion. So you need to, suppose if the patient is going to present with you, present with evidence of jaundice in the background of chronic alcohol intake, doesn't mean that in the background of chronic alcohol intake, along with evidence of coagulopathy, along with evidence of minimal ascites, all this presentation can happen even in alcoholic hepatitis, but doesn't mean that is only because of alcoholic hepatitis in the field of gastro. So always you should work up the presentation. We need to rule out other possible differential diagnosis. It could be because of any coexisting pathology. Even if the female patient is going to consume alcohol, we are not very sure that it's only because of alcohol. We need to rule out autoimmune pathology. Sometimes in slightly younger age group, adolescent age group, children can also present with worsening of symptoms. Then we need to rule out any metabolic liver disease. So all these things has to be ruled out, and viral enteritis is one strong pointer, because hepatitis B and C, always the occult pathology will be there, and always we need to rule out hepatitis B and C are the coexisting infections, whether it is that supervein in the pathogenesis of alcohol-related liver disease. So when you want to say that alcoholic pathology is there or not, you need to rule out the other possible differential diagnosis. It's only a diagnosis of exclusion that has to be strongly kept in mind when you're going to work up on a patient with alcohol-induced liver injury. So what are the factors which affecting us and discuss with you is mainly because of the genetic pathology, because of your coexisting other complications, how much of dose you're going to take. Women is more vulnerable. Sometimes coffee consumption, there is strong evidence because sometimes it also acts as an antioxidant and anti-fibrotic effect, which has been well documented in the evidence of non-alcoholic fatty liver disease. But even in alcoholic liver disease, there is some evidence of fibrotic regression still being documented, but there's not much of area to discuss right now. See, so all the genetic variants, you have been thinking about that. Some patients have been consuming so much of alcohol, and some patients will not be taking any alcohol, but even after that, the patient will land up with multiple complications because of the genetic makeup of how the liver is going to build up. So all these things will be taken into account for you to develop cirrhosis and other complications to set in. So Symptoms and signs are very simple. So always the chronic liver disease, we need to analyze the patient is going for evidence of anemia, lethargy, lassitude, abdominal pain, and alcohol-induced neuropathic changes, weight gain or loss because of ascites or because of nutrition deprivation, which is nothing but sarcopenia. And apart from that, sexual desires, everything is going to come down. And once a patient, what are the various signs means is well known about the chronic liver disease, right from a basic knowledge. We look for all the stigmata of chronic liver disease, starting from your head to foot. So nothing but the hair loss, along with evidence of ectic changes, spanner, anemia, all these things, along with evidence of ascites, all the pointers for evidence of chronic liver disease, all these pointers can be taken into account. And always when I'm pointing about the patient in the background of anemia, doesn't mean that it's only because of a nutritional anemia. It could be because of iron deficiency, and most commonly in the background of alcohol-related liver disease, the patient can land up with megaloblastic anemia, sometimes folate deficiency because of methionine metabolism pathway, and also sometimes the patient can land up with hemolytic pathology. So all these things, all the variant type of anemias, all these things can report in if the patient is going to consume alcohol without any evidence of abstinence. So the first discussion, how common that fatty liver is going to progress. So if the patient is going to consume alcohol over a period of 4 to 6 weeks, around 90 to 100% of the population is going to definitely land up in evidence of fatty liver. And there may be evidence of AST, ALT elevations, but will not be very significant, will be less than 50 to 100. And apart from that, bilirubin elevation may be there, and it's rarely diagnosed, but but most of the patients were asymptomatic at the time of presentation. So how the fatty liver is going to progress. See, if you're going to look into this, so what is the mechanism which is going to increase your fatty acid synthesis? What is the mechanism which is going to reduce your lipid peroxidation pathway? So if you're going to see that there are multiple products, see, alcohol-induced liver injury, always you should remember the pathogenesis is very interesting. One is because of direct toxicity, and another one is because of indirect toxicity. The direct toxicity, the alcohol itself will be predisposing to direct toxicity. So how the alcohol is going to predispose? 3 major enzymatic pathway. See, this is on an outline. So you just remember 3 major enzymatic pathway. What are the 3 major enzymatic pathway? One is because of that aldehyde dehydrogenase, which is a key metabolic factor. See, the alcohol metabolism, almost 80% will be happening in the mitochondrial pathway. So what is going to happen? The acetaldehyde, once alcohol is going to get metabolized to acetaldehyde because of the aldehyde dehydrogenase, alcohol dehydrogenase. So it should be, once the acetaldehyde is going to get formed, there will be evidence of formation of ADEX will be there, ADEX formation, acetaldehyde ADEX formation will be there, which predisposes to cellular protein activation in your hepatocyte system. Once this gets activated, there will be activation of your immune response, and this acetaldehyde is going to get metabolized to acetyl-CoA, also and to acetate. So in this process, there may be a generation of NADH from NAD, which will set changes in your redox potential. So this is one because of aldehyde. There are various isoforms that are not out of discussion. And always you should remember that aldehyde dehydrogenase is one pathway. Next, oxidase-based system, oxidase enzymes, which has been predominantly located in your smooth endoplasmic reticulum. In this system also, so there will be enzymatic activation of CYP2E1 pathway will be there, and CYP2E1, once it gets activated, that oxidase ethanol to acetate will predispose to free radical release, will predispose to lipid peroxidation, will predispose to mitochondrial damage. See, all these things can happen, and along with that, the AMP kinase pathway and the ACC activity, acetyl-CoA activity, and CPD, carnitine palmitoyltransferase activity, everything is going to come down, and followed by your steroid response element binding protein will be increasing, and PPARs will be going to come down, followed by the lipogenic enzymes will go high, the fatty acid, the beta oxidation pathway will go down, followed by the patient can develop evidence of fatty liver, and based upon all these various enzymes which is going to be involved in this mechanism. So what is this alcoholic hepatitis? As we all know, many patients can land up in fatty liver, and few patients can develop alcoholic hepatitis. That's what I've been discussed. So once the patient is going for alcoholic hepatitis, sometimes the patient can land up in dangerous liver cell failure. And always you should remember this common entity, how to differentiate this alcoholic hepatitis from acute and chronic liver failure because of alcoholism. That's one most important thing, because alcoholic hepatitis, if you're going to see a patient, if your patient is going to come to your center, and if your patient is going to be examined by you, Always you should remember that if the patient is having evidence of hepatomegaly, and if you're going to do a imaging pathology, if you're going to do a imaging, in the imaging, if you're going to see a large liver in the background of minimal ascites, suppose there is possibility for this patient to land up with alcoholic hepatitis. Once a patient is going for a cirrhotic background, which means the shrunk out state of liver along with the massive ascitic generation, there is high possibility for this patient to go for acute and chronic liver failure, and rather than these kind of patients to land up only with alcoholic hepatitis. Another picture. So alcoholic hepatitis means will be an inflammatory pathology is already sets in, which will predispose to fever, jaundice, and signs of decompensation can be there. And lab parameters, always you should remember to walk up this alcoholic hepatitis can always predispose to coexisting other infections like pathology. So leukocytosis will be the AST-ALT ratio usually may be going up to more than 2, and alkaline phosphatase, bilirubin, albumin, bilirubin is going to go high, and albumin is going to come down, and prothrombin time in coagulopathy factors is going to be prolonged. So what is this alcoholic cirrhosis? Which means the patient will be, once the patient is going to consume alcohol without any evidence, without any stoppage in between, the patient can go for cirrhotic background, which will, once the patient is going for cirrhotic, sometimes the patient may be asymptomatic at that point of presentation. Mild, the bilirubin may come down, a mild increase in transferases. Apart from that, the albumin levels may go down, and thrombocytopenia and stigma of chronic liver disease is going to be established. So how are you going to rule out this pathology? See, always you should remember, mainly by a liver biopsy can be aided for you to conclude this kind of precipitation. But liver biopsy, no need to do for all the patients who are going to suspect with evidence of alcoholic hepatitis. It will always aid you in diagnosing other coexisting pathology, if you want to rule out any of the differential diagnosis, C-related pathology or any metabolic workup, this only in those scenarios liver biopsy. Apart from that, you're diagnosing very clinical spectrum of alcoholic. Most of the time, the liver biopsy is not considered much in the diagnosis of alcoholic hepatitis based upon your clinical presentation. But once you want to label ALH alcohol, always you need to look for ballooning degeneration with PMN. That will be going very high in case of alcoholic hepatitis, and megamitochondria changes will be going down in cases of alcoholic hepatitis. And once the patient is going to land up with, cirrhotic related changes, the patient value of Mallory dense bodies will be going very high, and fibrotic pathology is going to be raised. So these are all the various subtypes of aldehyde dehydrogenase and other enzymes that what I've been discussed with you. And as I see, if you're going to look into this aldehyde dehydrogenase pathway, that it's been located in the multiple tissues, mainly in the liver as well as in other systems also been involved. And if you are going to look into other methodology of this, and this is what been discussed about this enzyme-based activation of liver injury. See, that's what been showing in this slide. Once the astralgate attacks, everything is going to form. The depletion of glutathione is going to set in, followed by the oxidative stress is going to be established. What is going to happen? The hepatocytes will be predisposing to multiple pro-inflammatory cytokines release, will be having a Kupffer cell depletion. Kupffer cell will be in a pathogenetic form, followed by the patient liver sinusoidal Kupffer cell injury. All these things will be predisposing, which will make you to progress to liver fibrosis and other complications. Apart from that, there are multiple other indirect modality for you to develop this kind of cirrhotic, alcoholic hepatitis being involved in the form. There are other pathways also being included. For example, if you're going to consider this folate metabolism pathway, it's nothing but the methionine and S-Adenosylmethionine can be considered. So once the level of S-Adenosylmethionine is going to come down, that will predispose to raise levels of homocysteine, which will make you to be in reduced form of tetrahydrofolate, which will predispose to further liver injury and other damage to set in. Apart from that, the one recent interesting area is leaky gut syndrome. So what do you mean by this leaky gut? Once alcohol is going to damage your gut permeability factors by your gut, always you should remember, that's why there've been trial of fecal microbiota transplant and other things being involved in the consideration to manage a patient with alcohol and other alcoholic hepatitis. So once the patient gut permeability is going to get damaged, the mucin production is going to come down, followed by what is going to happen, the LPS, the lipopolysaccharide activity of all the bacteria is going to go high. Once the lipopolysaccharides is going to go high, there will be evidence of toll like 4 receptor activation will be there, which will further predispose to pro-inflammatory cytokines and hepatic injury. All these things will be predisposing to multi-organ failure and multi-organ injury. That's a pathology also for ACLF can be considered. So what is the role of inflammation? So how the inflammation is going to set in, that is mainly because of innate immunity and also because of this adaptive immunity. So what is the innate immunity? As what have been discussed, the lipopolysaccharide activation is going to be, the pro-inflammatory cytokine activity is going to be high, and apart from that, there will be evidence of infiltration of neutrophils as well as macrophages. The adaptive immunity, what is going to happen? The reactive oxygen species is going to generated, followed by the protein adduct formation will be worsening, along with the antigen presenting cells and immune response cells, which will be disposed to infiltrate of your T and B cells, and followed by the liver inflammation. Alcoholic liver disease is going to supervene. So the liver fibrosis, how it's going to develop is nothing but, as I told you, once hepatocyte apoptosis or necrosis, if it's going to get formed, there will be evidence of ROAs, reactive oxygen species generation, DNA apoptotic body fragments is going to be there, and necrotic debris is going to be there, along with TLR activation. So there will be injury to the stellate cells, which will predispose to extracellular matrix deposition, which will predispose to liver fibrosis in case of alcoholic liver disease. So this is how the mechanism of liver fibrosis and direct injury, and also by indirect injury in the form of your various enzymes and other pathways, along with your leaky gut syndrome. All these things will be predisposing to indirect liver injury, also mainly in the background of alcohol intake. So if you're going to discuss about this alcohol, how to analyze this alcohol. See, once a patient is going to consume alcohol, the patient most of the time will be psychologically deprived, and the patient wants to take alcohol. Even if you want to progress the patient for liver transplant, even if you want to progress the patient for basic workup, we are not very sure whether the patient will show evidence of abstinence followed by this presentation, or there is evidence of recidivism. So the patient can consume alcohol once again, even if the patient been treated in the initial phase. So all this can be analyzed. So there are multiple scoring systems are there. So the screening efforts are there. If you want to consider this alcoholic related liver pathology. So mainly there is one scoring system, what is called as alcohol use disorder identification test. In this, they will be labeling. There's almost around 10 to 11 pointers are there to consider in this. So 10 pointers are there to consider in this. Based upon that, the various questions, how often the patient is going to consume alcohol, all these various questions that will be easily available in net. That's not the main area. See, with this, if you are going to give your patient with this kind of questionnaire, and you can able to pick out this kind of patients who is having high potential for the patients who will go for alcohol, even post-transplant other scenarios. So audit C questionnaire, even the maximum scoring system will be around 12. A score of more than 4, it indicate the pointers to be considered more in favor of alcohol worsening symptoms. So this is nothing but another scoring system. What you're going to use, a cage scoring. It's nothing but cut down, annoyed, guilty, or high openers. Based upon this, whether the patient has been cut down the drinking or been annoyed because of that, followed by the patient consume alcohol, any time the patient have guilty feeling, is there any high opener in between? For these kind of patients, these are all the various outline of scoring systems what we use, and with that we can able to label the patient with having severe evidence of alcohol worsening symptoms are there or not. And what are the various biomarkers being used in alcohol abuse? Means there are so much of biomarkers that being frequently used, even in the urine, blood, and air. We can collect the various metabolites and other factors can be identified, but not one single biomarker can be considered as a strong potential indicator to consider that the patient is having evidence of alcohol abuse. So we can look for evidence of liver enzyme elevations along with bilirubin, and evidence of macrocytic anemia suggesting of megaloblastic and other pathology. So these things can be considered. And GGT also, you will be remember, the most common enzyme is going to get elevated, which is predominantly in the cell membrane in several body tissues, which will also include the liver and spleen. So if the patient is going to consume every continuous intake of alcohol, there is high possibility for this patient to go along with GGT elevation. But it doesn't mean it's only because of alcohol related disorder. It can be a non-specific pathology is also to be considered. So there are other various biomarkers like carbohydrate deficient transferrin assay, which is having a very short off-life of almost around 2 to 3 weeks. It's mainly generated by alcohol inhibition of transferrin glycosylation. So the utility for this kind of test is limited. There are multiple false positive results are being reported. But apart from that, there are new entities like ETS and ETG, which is nothing but ethyl glucuronide as well as ethyl sulfate also being used in the diagnosis of alcohol-induced disorders. So just please remember these two words, ethyl glucuronide, sulfate, and CDT and phosphoryl ethanol. All these things can be considered to diagnose the biomarkers for evidence of alcohol abuse is there or not. But based upon, if you're going to look into the study, which is given in 2019 guidelines of AASLD, what they mentioned about that, so there are multiple false positive reports, the lowest sensitivity and costly and cumbersome issues is there when you're going to look for this CDT, which only is going to diagnose a biomarker it's there or not, but doesn't going to improve your clinical presentation, doesn't going to improve your prognostic markers and other things. So the main area for me to take on right from now, how do you going to manage this kind of patients in the background of alcoholic liver disease and alcoholic hepatitis is the most important entity for me to discuss, because so the prognosis is always guarded. We need to analyze various scoring systems are there. So sometimes the patient may be morbidly obese, sometimes the patient may be having thyroid-related pathology, sometimes the patient may have hepatitis C virus-related infection, so many other coexisting complications, hypertensive, type 2 diabetes, coexisting other complications in the background of morbid obesity, in the background of metabolic syndrome, in the background of severe alcohol intake. So all this pathology can even worsening of clinical presentation. There are various scoring systems are there among them. So if you want to look, see, once the patient is going to develop this kind of complications, the possibility of mortality is going to be very high once the patient is going to land up with hepatic NCAF stage 3 or 4. So always the patient is going to land up with varices, GA bleed, hepatic NCAF. These are all based upon the Danish population study. They've been mentioned very clear statement that the patient's mortality is definitely going to be high. So histology, as what we've been discussed about the liver biopsy, can aid in the diagnosis to look for all malarians and other changes. Alcoholic hepatitis, once the patient been diagnosed, the possibility for them to survive at 4 to 5 years, even after quitting the alcohol, there is possibility for them around 50 to 75%. In the background of fatty liver, around 50 to 70 to 80% survival may be there. Once the patient is going to land up with cirrhosis, only 30 to 50%, around 4 to 5 years of survival records being documented as of in various data. So this is how we are being going to prognose. So once a patient is going to land up with cirrhosis and hepatitis, along with the probability of survival is definitely going to come down in this, which has been quoted from the Journal of Gastroenterology. And there are various prognostic models of being there. So always you should remember MELD scoring, Glasgow scoring, and ABIC scoring, as well as Lille scoring. See, Lille scoring is one which is being mainly used to assess the steroid sensitivity is there or not. I mean, apart from that, what is basic CPC child-box criteria based upon your right from your basics, from the pointers of 1, 2, 3, based upon your clinical presentation, based upon your lab values, they are being scoring. Once a patient is going to go into stage C, there may be around 10 to 15 points in this kind of presentation. So it's not very, very simple CPC. Once a patient is going to be in child-box criteria, if the patient is going to land up in child C cirrhosis, the possibility of this kind of patients to worsen with other complications is always there. And MELD scoring, because every patient will be having, even any normal patient will be in child age status. So not only that, so our main intention, whether the short-term mortality is there or not, for that we need to score the MELD scoring and other system is nothing but modified end-stage liver disease. And in the background of alcoholic hepatitis, the one sensitive scoring system, nothing but Madrid discriminatory function is very important, because Madrid discriminatory function, if you want to calculate, we need to use this prothrombin time in control, which is going to be multiplied by 4.6 plus serum bilirubin value. So if your score, if it is going to be more than 32, there is high pointer for you to land up with worsening of symptoms. For you to start the patient with steroidal support can be considered in the management. So alcoholic hepatitis, you should remember the management part is mainly by your nutrition support. And always you need to categorize a patient with mild, moderate, or severe symptoms. So mild to moderate presentation, only with your nutrition and basic vitamins and mineral support will be improving your clinical status. Once the patient is going to land up with severe presentation, or once the patient is having coexisting pathology like acute on chronic liver failure, then the management of liver transplant and other things definitely going to take on in this part of management. So So once the patient's being MDF is shows to be more than 32, that shows, which means the survival rate is going to definitely come down, and the patient has to be is initiated on steroid to assess the rate of response. See, and apart from that, there are various other scoring systems that what have been discussed for, like which Glasgow alcoholic hepatitis scoring system. And in this, there have been 5 pointers have been taken into an account. And always you should remember a score which is going to be more than 9 is strongly pointed towards a worse prognosis in case of GAHs. And ABIC scoring is also based upon your age, bilirubin, INR, and creatinine. In this scoring system also, if the patient's cutoff value, if it is going to be made, if the patient's 6.6 to 9, so there may be a possibility of low, intermediate, or high risk of death for this kind of patients to progress. So this is based upon the various scoring what have been discussed, like ABIC and other things. The survival probability, once a patient is going to be having high score, the possibility will be coming down. And the most important, very interesting, apart from MAD, is the model for MELD scoring system based upon your bilirubin, INR, and creatinine, which is being more frequently used. The maximum scoring will be around more than 40 if the patient is going to land up. The possibility of survival for this kind of patients will be very low, around 70 to 80% definitely is going to succumb because of this kind of alcohol-related liver disease. And if score tends to be very less, for example, if it is less than 10, the possibility of survival for this kind of patients will be more than 80 to 90% for this kind of presentation. So what is this Lille's model, which is there is a curve-based scoring system, Lille's curve, what they're going to use in that. So this is the proportion what they've been taking into account. So if the patient is going to be on steroids and the patient has to show a response within a period of 7 days, if there is no response, if the Lille score is going to be more than 0.45, that shows there is evidence of worsening of symptoms even in the background of your steroids, and you need to stop the steroids for the management of alcoholic hepatitis. So it predicts a poor survival in the background of alcoholic hepatitis. So the Lille score is most important to categorize once the patient been initiated on steroids. So what is this Lille scoring? Nothing but based upon your age, albumin, bilirubin at day 0 and day 7, and creatinine at day 0 and prothrombin time at day 0. So based upon that, you need to calculate your Lille score. And this is how we've been, we need to various scoring systems. See, based upon that, the Lille score will be around 0.45, more than 0.55 in between the values. So if it is going to be more than 0.55 and other symptoms, the possibility for this kind of patients to go for still worsening of liver failure and other, alcoholic hepatitis is there to take on. So this is how the outline of all the scoring systems being used in the diagnosis of alcoholic hepatitis. And to come to the management part, always you should remember, anytime, so even if the patient is having evidence of fatty liver, or even if the patient is having evidence of alcoholic hepatitis, or even if the patient is having fibrotic changes, or else the patient is going for cirrhotic background. Always you should remember that alcohol will always be considered as a co-carcinogen. There may be possibility, even B and C is the main reason for hepatocellular carcinoma to predispose. Alcohol also can worsen the patient to land up in HCC. So always alcohol can be considered as a co-carcinogen. You need to stop alcohol. That's the most important point to advise the patient. Once you stop the alcohol, the possibility of survival, as quoted in multiple papers, since lack of time, didn't quote all those things. The multiple papers are there. Once a patient been stopped alcohol, there is possibility for that kind of patients to improve during the course of presentation. So alcohol abstinence, stoppage of alcohol is the most important rule to be followed in the management of alcohol-related liver disease. And the most of the patients will be having evidence of cirrhosis. The patient may have evidence of hypoglycemic symptoms. So always you need to give a nighttime snack for this kind of patients and frequent small feeding. Our nutrition target will be around 30 to 45 calories per kg per day, has to be maintained, along with the protein supplement around 1.5 grams per kg per day has to be maintained, unless and otherwise if the patient doesn't going to land with hepatic encephalopathy and other kind of presentation. So the diet and nutrition is the most important thing, and the micronutrients like all the thiamines, vitamin B12, folic acid support, all these things can be added in the management. And what about that for alcohol abstinence, in order to reduce the alcohol craving, That is one more thing I want to, and since I didn't add up in my slide, that is also can be considered like acamprostate, naltrexone, and all these things can be tried in the in the abstinence of alcohol. Also, baclofen that is having strong potential role to be considered in the management to reduce alcohol craving and other things. So frequent small feed, nutrition support, that's the most important thing. Once a patient is going to land with worsening of symptoms, the patient may need enteral nutrition. Even after that, the patient still landing up in multi-organ failure like ACLF. Like if you want to look into this ACLF pathology, the period of establishment within a period of 4 weeks of symptoms like ascites and encephalopathy and coagulopathy and worsening of bilirubin will be there to document ACLF. And there are multiple canonic and other studies being there to show that once a patient is going to develop evidence of organ failures, like single organ or multi-organ failures, once a patient is going to land up with that kind of presentation, the patient may need a parenteral nutrition support also. So always you should remember that the nutrition part to take care of sarcopenia, other things, the restriction of salt and other things, once the patient is going to land with ascites and other complications. So most important thing to check on. Apart from that, what are the other medications? The new list has not been discussed. The main role is only because of steroids, whether you're going to start or not. Apart from that, the liver transplant is there and various hepatotoxic medications, stoppage of alcohol, quit your smoking, vaccination for your A and B, also for your flu-related pathology, also for your pneumococcal vaccination has to be considered. So general measures that what have been discussed. So we need to analyze all this measures along with your protein intake at least on 1.5 grams, unless and otherwise if the patient is not going to land up with any hepatic encephalopathy. So the most important thing when you're going to land up the patient, we're managing a patient, there may be ACPN negative nitrogen balance may be there in the background of alcoholic hepatitis. So the patient can land up in acute renal failure. Sometimes the patient can take, can be even worsening by hepatorenal syndrome. As we are discussed now, the hepatorenal syndrome type 1 and type 2 is not in news. We need to know that hepatorenal syndrome is mainly because of AKA or non-AKA related pathology. That's a separate area for discussion. So always renal failure can also worsen your clinical presentation. So when you're going to subject the patient with fluids, avoidance of radio contrast, all these things to be taken into account if you're going to manage a patient with hepatorenal syndrome, that will usually develop once a patient is going to land up in cirrhosis based upon your vasoconstrictive pathology. So there is high possibility for you to take on this kind of presentation. Once a patient is going to land up with HRS, the patient can worsen in the clinical presentation of management of cirrhotic alcoholic hepatitis. So cirrhotic alcoholic liver disease. And always you should remember there are multiple coexisting infections will be there. Once a patient is going to have infection, the possibility for you to start the patient on steroids is not to be done, because always you should remember if you want to start the patient on steroids, you need to rule out the source of infection. You need to do a blood culture, urine culture, you need to take a CT chest or X-ray chest, or you need to do a tuberculosis workup prior to initiate the patient on steroids. Because I have seen some patients in my experience, I have seen some patients even after initiation of steroids, because steroid initiation is one of the difficult even for the gastroenterologist to consider the management of alcoholic hepatitis. Because if you're going to initiate on steroids, we need to document the Lille score, other things. Serially, we need to monitor the patient for worsening of other symptoms. Also, we need to see through that the patient doesn't going to develop or land up in any major infections. Even in our personal experience, we have been coming across some patients may develop occult infections, which is going to worsen if the patients have B or C. Any other complications can worsen in the background of alcoholic hepatitis once the patient is going to initiate on steroids. So the most important thing, we need to rule out all possible source of infections. And apart from that, if the patient is going to be a bleeder, if the patient is going to present with evidence of a UGA bleed in the form of melena or history of any emetamasis or melanomasis, what is going to happen if the patient is having UGA bleed? You are not supposed to use the patient on steroid. Along with that, if the patient is going to have severe renal injury, the steroid use has to be considered, not to be considered much. Along with if the patient is having evidence of pancreatitis, a septicemic and other focus, no need. The initiation of steroids should be withheld in this kind of presentation. So we need to document all sorts of infections. As I discussed with you, this has been taken from the AASLD guidelines. The alcoholic hepatitis, if you want to define, means the onset of jaundice in a period of 8 weeks and the worsening of symptoms over a period of 6 months. or if the patient is going to consume more than 40 or more than 60, with less than 60 days of abstinence will be the AST ratio, ALT ratio is going to be elevated, and your serum bilirubin will be high, more than 3. So it shows that possibility of definite alcoholic hepatitis can be considered. The confounding factors like your drug abuse or any metabolic suspicion, or if the patient having UGA bleed, and atypical lab pathology like AST definitely is going to be low, all these things, and presence of autoimmune markers like ANA, ASMA, ALA, SLA, all these things can be taken into account as a confounding factors in the clinical suspicion of alcoholic hepatitis. So based upon that, AASLD has come with the diagnosis of definite possibility or probable possibility or possible clues are there for alcoholic hepatitis can be considered. So based upon this, when you're going to initiate the patient with steroids, if the MD of mandatory discriminatory, if the patient is going to be more than 32, your MELD if it is going to be more than 21, that is, these are all we need to. MELD means which you assess the prognosis, habit to assess the prognosis, and Lille scores mainly you need to see through that whether the steroids should be continued or not on day 7. So regarding the discussion about the corticosteroids, the most important thing, how are you going to give the dose of corticosteroids? So I may give for a period of 28 days of corticosteroids. Oral steroids can be considered. And once a patient has been considered for a period of 28 days, I may taper the dose for a period of around 2 to 3 weeks slowly. And we need to assess the patient with complete response or partial response or null response based upon the Lille scoring system. So complete responder means your Lille score will be less than 0.16, and your null responder mean it should be, if it is going to be more than 0.56, that's what I've been discussed to you prior to that. So the complete response, the survival benefit is definitely going to be high. Once the patient is going to a null response, the survival benefit is going to come down. And what are the other modalities to consider? The N-acetylcysteine, glutathione, so many other molecules. Briefly, to brush up, what are the things to be added in the armamentarium of management of alcoholic hepatitis, like NAC, so one of the strong potential antioxidant, TNF pathway inhibition. So that can be considered in the dose of around 600 milligrams twice daily. Also, you can give IV or oral formulation based upon your clinical presentation. There are various papers are there to quote the beneficial effects of NAC over a period of 7 to 10 days when you're going to manage a patient with alcoholic hepatitis can be considered. And apart from that, the newer line of treatment like GCSF also can be considered. See, once a patient, if you're going to subject the patient with steroids and other liver supports, and also should remember the various hepatoprotective factors like UDCA, metadoxin, so many other things are there, but I didn't add up in all those slides. All these things didn't show much of beneficial effects. And even silimarin, that I'll be showing some of the slides in my upcoming presentation, but silimarin also can be considered, but this all still need more papers to show the evidence and of response to the clinical presentation. Like when you're going to consider this GCSF, if you're going to subject the patient for around 5 mg per kg, it is going to mobilize your bone marrow cells from the marrow, and it's going to improve your clinical presentation. Liver stem cells generation will be there. The hepatocyte formation is going to be there. And you can subject the patient for around 5 days, 5 mg per kg, that can be tried. Every 12th hour, if you're going to give, there is possibility for this patient to have a minimal worsening of symptoms. And also you should remember pentoxifylline. There are many centers, some centers they are using pentoxifylline and some centers will not be using pentoxifylline. But my personal experience, definitely you can consider to avoid the short-term mortality, because short-term mortality, if you want to consider pentoxifylline, definitely you can consider, but based upon the monitoring, since it's a phosphodiesterase inhibitor, we need to monitor the clinical presentation of vascular system and other complications. We can give pentoxifylline at a rate of thrice daily. If you're going to look into STOPA trial, see what have been mentioned, that once the patient has been subjected, the overall beneficial over a period of 3 months mortality, it's not going to be much of beneficial role is going to be there with pentoxifylline, but there is possibility for this kind of patients to improve the short-term mortality and also to improve your renal complications like hepatorenal syndrome and other presentation. So pentoxifylline also can be considered to avoid the short-term mortality. And if you want to discuss about the silimarin, it has been derived from the natural source of extract like milk thistle. So, and if you're going to look into the silimarin, So it is also having a strong antioxidant property and also been involving in the cytoprotective effect. So as we all know that the free radical generation, ROS generation is the most important thing, and adduct formation, all these things, and followed by your DNA degradation, RNA and other protein formation, everything is going to be definitely come down in the management of acute liver pathology. So in this, for this, if you're going to use silimarin, there is some possible beneficial role can be considered. See, once if you're going to use silimarin, it acts on various polymerase, RNA polymerase, other thing, which increases, so what is going to happen? They increases ribosome protein and DNA production. So silimarin is going to improve your regeneration of hepatocytes. So it has shown there are some beneficial effects on anti-inflammatory property. If you're going to consider silimarin, you can think in terms of alcoholic hepatitis. There is some in mild form of alcoholic hepatitis can be considered. If the patient is having acute viral hepatitis, can be considered in the management, but we need more papers to quote all these beneficial effects. So it also suppresses NF-kappa B, inhibits 5-lipoxygenase, and suppress your T lymphocytes, and it overall reduces your inflammation. So this will augment for your cell proliferation and survival, and inflammatory pathology, everything is going to come down. And this is how silimarin is going to have an anti-fibrotic effect also. So as you all know that the fibroscore is one of the most important fibro scanning system being used. So once a patient is going to land up with fibrosis followed by steatosis, steatohepatitis, and other complications, there is some papers being quoted that once you have been subject the patient with silimarin, it shows evidence of activation of interface with stellate cell activation, which will avoid your worsening of your liver injury. So there are some possible beneficial as antioxidant, and it protects us a bit. So glutathione, it will replenish your glutathione stores. Also it's having evidence of anti-inflammatory property. And if you're going to subject the patient, almost if you're going to give around 400 milligrams, so there is possibility for this 420 milligrams TID dosage can be considered in the management of alcoholic hepatitis, and other things can be added. And this is how the various outline scoring system is the overall guidance to maintain the nutrition, steroids, pentoxifylline, and along with the silimarin and other things. Apart from that, the micronutrient factors, like all these things to be taken into account. See, this is how we need to have an algorithmic approach. See, the stepwise algorithm. First, we need to categorize the patient, whether the patient is going for alcoholic hepatitis or the patient is going for ACLF. So based upon the categorization, we need to decide whether the patient deserves steroids or not, whether the patient is having evidence of contraindication is there or not. Once the patient being deserves the steroids, assess your Lille score for on the day of 7. Once a patient is having signs of improvement, continue the steroids and slowly taper. No improvement, consider other line of treatment and progress the patient for liver transplant as early as possible. So this is all the alcoholic hepatitis. There are some modalities, some molecules being tried like SAM and propylthiouracil, colchicine, but anabolic steroids. There are so many molecules there to document some beneficial role, but we need still more papers to augment, and overall trial doesn't show much of improvement over the period of survival over a period of 3 to 6 months. The overall mortality doesn't going to improve even with you're going to subject all these molecules once the patient is going to land up with severe alcoholic hepatitis. So always you should remember the liver transplantation is one of the most important thing prior to the patient going to land up in ACLF and other complications, child C and other status. So alcoholic cirrhosis is one of the strong potential indicator in Indian background. The liver transplantation criteria has to be strongly considered. So once a patient is going to be a child C status or MELD, if it is going to be more than MELD sodium status, if it is going to be more than 21, the possibility of liver transplantation for this kind of patients to consider in the background of alcoholic hepatitis if there is evidence of worsening of symptoms. So liver transplant is one of the most important thing, and there are other liver aided supports like MAS, plasmapheresis. Once a patient is going to have worsening of bilirubin, other things can be aided as a bridge to therapy, but not considered as a strong potential marker rather than going for liver transplant. Because liver transplant, once the patient's MELD is going to be more than 21, the steroid response is not to be strongly augmented, and there is no single molecule being showing evidence of good beneficial effects in the management of alcoholic hepatitis. And in the background on nutrition deprivation, the patient is going to land up with sarcopenia and other things. Always you need to consider this patient as early as transplant to be progressed, even as a disease donor or a cadaveric, living donor transplant to be considered. This kind of patients has to be initiated in the right time if you're going to manage a patient with alcoholic hepatitis, particularly in the background of severe alcoholic hepatitis. So as I discussed with you, in case of alcohol based upon NAA, and if you're going to think about this, in order to overcome this abuse pathology, there are multiple molecules can be tried. My personal experience, I will go for baclofen most of the time, and sometimes I will be going for acamprostate also based upon NMDA receptor antagonist. So these are all the molecules can be tried, but that shows nothing, no other single molecule has been beneficial role. Once the patient is having alcohol withdrawal states like Vernix, Cosacols, all those pathologies, you can try thiamine to some extent to show some beneficial effects is there or not. So what are the recent therapies? What are the future targeted therapies? That's what been discussed with you all. The latest trends, what's being happened, as you all know, the liver transplant on the fecal microbiota. So what is going to happen? So we can try that selective intestinal decontamination. What is a selective intestinal decontamination? One is mainly by your rifaximin, Norflox, and other support. And what is this called? Antibiochar. It's nothing but you're going to give amoxicillin along with clavulanic acid at higher dose in the bank. There are some evidence being shown that with the background of prednisolone, along with steroids, you can give a single dose in the morning for a period of 30 days. There are some trials to show some beneficial effect, which will reduce your endotoxin levels. So there are multiple trials and papers are going on, but still need more consideration. Also, bovine cholesterol, if you're going to think that even for non-alcoholic fatty liver disease, and also for your fatty liver, alcoholic liver disease, that shows some evidence of bovine cholesterol, which is having a strong anti-LPS antibody in the background of 20 grams TDS. Also, if you're going to give zinc, which is going to interfere with the mucosal integrity. And one important thing like FMT, fecal microbiota, being tried in few centers in India, one in ILBS and PG Chandigarh, some papers, mainly in ILBS, they have been tried. And what they have mentioned in that, so the gut bacteria dysbiosis will be going to come down and the symbiosis is going to be established. And for a period around 7 days, we've been trying with the paper, 1 week trial of fecal microbiota transplant being there. But that shows some evidence of septicemia as being worsening even after that. But most of the patients, we need a large trial to analyze this FMT, whether it is functioning or not. And apart from that, there are some additional molecules to end up before ending up the session. So to deactivate the liver innate immune response, so we can try anakinra at a dose of, it's nothing but interleukin-1 antagonist. So along with pentoxifylline or a period of 14 days in the dosage of almost around 100 milligrams subcutaneous. If you are going to drink, there are some evidence of worsening, deactivation of your liver innate immune response can be considered, but we, as of now, the strong beneficial effects in the role of mortality has not been there to prove with that. So apart from that, the hepatocyte transplantation, attenuated hepatocyte necrosis with your pan-caspase inhibitor like emricasan can be tried, but there is no evidence of significant results. Now newer papers are coming out with interleukin-22, what they've been showing that this cytokine is also a hepatoprotective, and based upon your Chinese hamster ovary cell extraction, what been tried. So these are all things can be tried. And one interesting entity like obeticholic acid, as well known in the background of NASH and primary biliary cholangitis, what they may consider. There are few papers being reported. Some patients having evidence of severe alcoholic hepatitis, moderately severe alcoholic hepatitis, can have a beneficial effect. So what is this obeticholic acid? Nothing but FXR agonist. So what is going to be farnesyl X receptors agonist? So it is going to suppress your bile acid synthesis from your cholesterol, which will regulate your triglyceride levels. So there are multiple doses from 5 milligrams, 10 milligrams being available in the market right now. So we can give 10 milligrams once a day orally for a period of almost 6 weeks to aid in the management of your alcoholic hepatitis also. So there are some papers to show the beneficial effects. Apart from that, the monoclonal antibody like simtuzumab being there to try to alter your extracellular matrix enzyme promotion and other things. So if before concluding, I would like to say the one difficult task is to diagnose alcoholic hepatitis. And once you diagnose alcoholic hepatitis, to whom you are going to subject the patient with steroids or not, that's the most important thing. The nutrition support, the enteral or parenteral or oral all these things, along with the frequent small meals, has to be taken into account, and along with awareness of hyperglycemia, take care of your comorbidities, and stop alcohol. That's the most important thing to take over. And along with that, what is the drug which is going to be considered, whether the patient is being subjected to early liver transplant has to be done or not. All these things to be analyzed properly in our clinical scenario. In our Indian status, our alcoholic liver disease tops the list for a liver cirrhosis and other pathology. So always you should remember, abstinence of alcohol is the most important thing. Stop alcohol either by today or else you will be nowhere by tomorrow. Thanking you all for patient listening, and I'm happy to take up your questions if anything is there to take over.
Thank you, sir. It was a wonderful presentation, sir. It was a comprehensive knowledge, like we all obtained about the alcoholic liver disease. There are a few questions to take up, sir. This is from Dr. Velu Chami. So he's asking if there is fever in alcoholic hepatitis, how do we treat, sir? What is the method of treatment?
Couldn't get you. So what is the question? Cirrhosis and alcohol.
Sir, if there is fever in alcoholic hepatitis, so what
Once
is the modality
is having evidence of fever, always the antipyretic you are supposed to, in the background of worsening of alcoholic hepatitis, 1 or 2 doses of antipyretic doesn't going to alter your liver function, but the paracetamol and other toxicity, there is possibility for this kind of patients to worsen. Always you need to manage conservatively with your tepid sponging, other support, rather than going for antipyretic support in the management of a patient with alcoholic hepatitis, because it's always very difficult to assess the dose, what you're going to respond, because our Indian scenario, the education rate is definitely very low for the poverty and below lying social status patients. So sometimes they may consider too much of antipyretic medications that may worsen your scenario. So antipyretic medications will always be a last entity only if the patient has severe worsening of febrile events. At that point of juncture, you can give this antipyretics rather than initiating in the initial point of presentation.
Thank you, sir. Sir, another question, sir. Sir, how long this baclofen can be given in case of alcoholic hepatitis, sir?
So there are some papers, some trials in which have been considered if you can give around up to around 10 milligrams, we can consider even up to 8 weeks of therapy for management of alcohol withdrawal and other supports. 8 to 12 weeks, we can consider baclofen also. But these are all the add-on molecules to show, but once a strong determinant for them to stop alcohol, that's the most important thing for the patients to consider in the management of alcohol-related liver pathology.
Okay. Thank you, sir. Another question. So what is the role of UDCA in alcohol?
Thank you, sir, for this question. So if you're going to use the UDCA, many, even for the gastroenterologists, many physicians, surgeons, everyone is going to use UDCA for any alcohol-related, many liver evidence or liver pathology. See, whether the UDCA is having a hepatoprotective beneficial role in the background of alcoholic hepatitis, it's definitely not been proven much, and there are no papers, significant papers to improve the mortality in other status. So at mild form of alcoholic hepatitis, along with the nutrition support, along with your minerals and vitamin support, you can consider adding UDCA, but to document the paper evidence as per the various guidelines, there is no significant benefit if you're going to consider UDCA, that too in the management of severe alcoholic hepatitis. The possibility of using UDCA is definitely a questionable issue.
Okay. Thank you, sir. Sir, there is another question. So what is the role of S-Adenosylmethionine in alcoholic hepatitis?
So S-Adenosylmethionine can be considered in the management of alcohol hepatitis. That's what been discussed. So 400 to 400 milligrams to start with. We can go up to 1,200 milligrams per day because it's going to alter your folate pathway. See, if you're going to look into the folate pathway, the S-Adenosylmethionine is going to come down along with your homocysteine levels is going to go high. That's what I've been shown in my initial slide. So you can consider S-Adenosylmethionine in the management of alcoholic hepatitis, but these are all for milder to moderate forms, but not in the severe forms, no potential beneficial roles, unless and otherwise the patient is not going to form, going to this liver transplant.
Okay, sir. Another question, sir. What is the role of fecal microbiota transplant in alcoholic hepatitis?
Role of fecal microbiota transplant, as per my personal experience, we have not been done much in our centers as of now. Only very few centers in India are being tried for a period of almost 7 days. But there are some papers being quoted with evidence of septicemia in that. Based upon US also, there are some papers to quote with evidence of some septic focus in that. If you are going to manage a patient with alcoholic hepatitis, only the moderate to severe form we can consider along with for a period of 7 days FMT transplant, but the cost constraints, other things, the evidence of septic formation, all these things, all these pointers, we need still more larger database to analyze this FMT is working or not in the management for alcoholic hepatitis.
Okay, thank you, sir. So another question, sir. So what is the role of obeticholic acid in alcoholic hepatitis, in severe alcoholic hepatitis?
That's what I've been discussed. There are some severe alcoholic hepatitis, not much of papers have been there, but in mild to moderate, there is some evidence to show that based upon foreign or X receptors agonist, it's going to alter your bile acid metabolic pathways, which is going to upregulate your triglycerides and improve your triglyceride synthesis and other things. So there shows some evidence of in alcoholic liver disease also, but the primary beneficial role in the background of primary biliary cholangitis, also in the background of non-alcoholic steatohepatitis is slightly higher when you're going to treat a patient with alcoholic steatohepatitis. And we can consider dose of around 5 to 10 milligrams slowly over a period of 4 to 6 weeks can be considered as per the various papers what have been tried. But we need more papers to document the role of obeticholic acid, which is a new upcoming molecule in the management of alcoholic hepatitis.
Thank you, sir. Sir, how to give steroids in alcoholic hepatitis, sir?
If you're going to use steroids, what we have been using frequently in our centers daily, frequently we'll be seeing across many patients with alcoholic hepatitis into whom we are going to subject the patient with steroids. Before subjecting, as I discussed with you, we need to rule out renal complications, pancreatic pathology. We need to rule out any upper GI, any evidence of source of bleed, along with the patients having any evidence of septic focus. That's the most important thing to be ruled out if the patient is going to start on steroid. So we can consider oral prednisolone, other things for a days of 40 to 60 milligrams per day if you're going to give, and you need to give for a period of 4 weeks. So followed by within a period of 7 days, you can able to come to the conclusion whether the patient is responding or not based upon your Lille score. That's what been discussed previously. And once you're going to subject, once the patient is going to improve, you need to complete the dose for over a period of 4 weeks. And followed by, we need to slowly taper the regimen and we can stop the period drug over another 2 to 3 weeks of time.
Thank you, sir. Sir, how to exclude infections before starting steroids, sir?
That's what, if you want to exclude the infections, we need to do a basic workup like all the cultures. That's the most important thing. And also you can look for the basic parameters like your procalcitonin assays or C-reactive protein assays. These are all can be added into the armamentarium to diagnose whether the septic focus is there or not. Apart from that, your leukocytosis, your neutrophilic, to lymphocyte ratio can be assessed if the patient is going to have worsening of septicemia. All these pointers can be having a clue, but once a patient is going to develop ACAL infections, even if you're going to look into that, always you should remember analyzing the ACAL B is also most important, because I have seen a patient after initiation of steroids many times in our center being ended up with worsening of your hepatitis B, which was previously undiagnosed. So always you need to remember that you need to look out the patient for evidence of ACAL hepatitis B also before considering the patient with steroids.
Okay, thank you, sir. So, sir, what is the standard cutoff for liver biopsy in case of alcoholic hepatitis based on the platelet count and INR, sir?
Based upon your platelet count and INR, you need to take the INR. If the liver biopsy is absolutely not a strong pointer to consider the patient to diagnose alcoholic hepatitis. It's one of the modality to rule out other possible causes of liver disease, like your metabolic liver disease or your autoimmune pathology. All these things to be ruled out if you are going to do a liver biopsy. Along with that, if you're going to do a liver biopsy, always you need to target the evidence of localized infections. Also, your INR should be less than 1.5. That's the most important thing. And your platelet count has to be more than 60,000. That has to be strongly documented if you want to go ahead with liver biopsy without any evidence of major bleed. So these things are all you need to document prior to go for liver, prior to induce the patient, subject the patient for liver biopsy.
Thank you, sir. Sir, what is the role of fibroscan in severe alcoholic hepatitis, sir?
So there may be evidence of false positivity will be there, because once the patient is going to have severe alcoholic hepatitis, which means the patient's bilirubin levels will be going to be high. Sometimes the patient may land up with ascites and other complications. So severe alcoholic hepatitis always that may high bilirubin levels will alter your fibroscan estimate and other status. So severe alcoholic hepatitis means don't do a fibroscan during that kind of presentations.
Thank you, sir. Yes, sir. Thank you, sir. So, and what is the role of Silymarin in alcoholic liver disease, sir?
Silymarin definitely anti-fibrotic, anti-inflammatory. And if you're going to consider Silymarin over a dose of around 410 to 420 milligrams per TDS dose, if you're going to consider Silymarin, its possibility beneficial role is being there, but mild to moderate forms, not in the severe alcoholic hepatitis, to be considered in the management. As we all know, Silymarin is one proven beneficial role since it's been derived from the natural source like MELD and other compounds. So there is some pointers for which we have been using Silymarin and for acute viral and other hepatitis also, but to some extent only in mild to moderate presentation, not to a severe presentation, but it's not an absolute contraindication in the management of alcoholic hepatitis. So we can consider Silymarin to use, but how far the survival rate, how far the mortality is going to come down, how far the overall prognosis is going to improve, all these things has to be more documented to analyze this kind of statements prior to that.
Thank you so much, sir. It was a really wonderful session, sir. We really learned a lot actually with this wonderful presentation, and we're really honored with this session. Looking forward with a few more sessions with you, sir. So with this, I would like to hand over the session to Savitri Madam.
Yes, sir. Thank you, sir. Indeed, it was a great presentation and a very good learning for all of us. I take this opportunity to thank each one of the audience also, both in Zoom as well as who are watching this program in the YouTube, right? And I would like to inform that Microlabs Limited was the first to launch Silibon in India, right? And Silibon, we have both tablets and suspension. Silibon 70 and 140 mg tablets are available. And Silibon suspension is Silymarin 35 mg per 5 ml, which is available in 2 packs, 100 ml and 200 ml. So thank you for this excellent presentation, Dr. Arun, once again. And we would wish to have much more learning from in the subsequent further future sessions. Thank you, one and all. Thank you.
Thank you, sir. Thank you.
Thank you all for patience. Thank you all.